We are now moving on to the next symposium, the Perioperative Endocrinology Symposium. I call upon the session moderators, Dr. Suresh Vashishta and Dr. Vanita Rajgopalan for the session. The chairpersons for this session, Dr. Prabhav, Dr. Varun Arora, Dr. R.K. Chowdhury, and Dr. Anshuman. So we are going to discuss different case scenarios. The first case scenario will be a 70-year-old lady admitted for bilateral knee replacement, found to have TSH of 15. I invite Dr. Sambit Das, moderator for the session. Our experts are Dr. Nilakshi and Dr. Arun K.R. Singh.
Thank you everyone. So at the outset I must thank the SPEED team for giving this opportunity, and this is a very important scenario in fact in the perioperative endocrinology symposium. So there are some expert panelists also there, Dr. Nilakshi, and so I'll start the case scenario. So case is Mrs. RP, who is a 70-year-old female admitted for bilateral knee replacement. The medical history is that she is a known case of primary hypothyroidism since last 15 years, hypertension since last 15 years, osteoarthritis bilateral knee joint, and medication history, if I can highlight, the patient is on levothyroxine 100 microgram, and just a note to that she used to miss medication quite frequently for few weeks in the last few weeks, and she is on telmisartan 40 milligram at night, and calcium carbonate 500 milligram twice a day has been started by the orthopedician for the last 4 months. She is also on vitamin D supplementation. So examination wise, height, weight are 162 centimeter and 94 kg. So the BMI comes out to be in the obesity range, 36 kg per meter square. The pulse BP were normal, but when we did a palpation, there was a grade 1 goiter which was diffuse and firm. Other investigations or the biochemical and the hematological investigation revealed hematological investigations were all normal, except that biochemical investigation or the hormonal involved TSH was 15, and when we did the free T4, it came out to be 1.4 nanograms per deciliter with a range in that lab of 0.9 to 2.3 nanograms per deciliter. The glycosylated hemoglobin was in the pre-diabetes range, that's 6.2%, and the creatinine was 1.5 milligram per deciliter with reduced GFR. 6 months back, when we evaluated or when we saw the investigation, the TSH was 4.8. So that was the case scenario. I think many times we come across this type of cases, and as a physician and endocrinologist, lot of time, almost in a day, we must be getting 5-6 referrals from orthopedics or other departments about clearance of these cases who are going for surgery, and those patients have been already admitted. So my first question to Dr. Nilakshi is, do we need to screen all patients preoperatively for thyroid dysfunction? So what's your opinion on that?
We see that thyroid disorders are quite common in the general population. So patients having thyroid disorders, they represent a huge part of the general population. Statistics say that hypothyroidism may be present in up to 5 in 1,000 people may have overt hypothyroidism, and subclinical hypothyroidism is even more common, 3 times more common than overt hypothyroidism. So having said that, thyroid hormones have a myriad of effects on the various systems, starting from central nervous system, cardiovascular system, to respiratory system, GI system, the renal system. So we see that the hematologic system is also affected. So we see that thyroid dysfunction is one of the important considerations that we should look for in a patient whom we are trying to evaluate pre-operatively, because we know surgeries have evolved. There has been a landscape transformation in the field of surgery as well, and now we see that successful and safe surgeries are being performed in progressively older population who have higher comorbid conditions, And hence, when we see that surgery has a safe outcome, a successful outcome, it acts as a confidence building effort for the physician as well as the patients. So it increases the number of surgical candidates and it improves the surgical outcomes. So it is necessary to screen maybe for thyroid dysfunction in population if they have symptoms suggesting of hypothyroidism, say they have presence of a goiter, and if history taking reveals that there could be symptoms related to hypothyroidism or hyperthyroidism, then we can screen such patients. But having said that, again, we have to remember that the symptoms of hypothyroidism are very subtle and we could easily miss them when we take our regular history, and hence maybe a simple test like TSH, which can pick up thyroid disorders, which is widely available, it can be used during the pre-operative screening for patients.
Yeah, I think that's pretty clear. Two things have come out. One thing is that routinely we should not be screening all patients who have been admitted for surgery. Only when we suspect some symptoms are there and the clinician finds a goiter or the anesthetist finds a goiter or there are symptoms, and as you told, there are some subtle symptoms also. So ideally we can do a TSS test. But if the patient is already hypothyroid and he or she gives an history of hypothyroidism, and within 3 to 4 months we have a TSH value which is normal and the patient is following the drugs regularly, I think we should not be repeating that test. But if there are some discrepancy or rise or lowering of the thyroxine dose, then we can check it preoperatively. So that should be the recommendation, and that's also the recommendation which I will discuss later on.
If I may add, at the outset, let me clear it that this row, I am a surgeon, he is a surgeon, he is a surgeon. Probably we are the students learning from you, but as a matter of standard protocol, we always go for TSH screen as a part of pre-operative screening. It's mandatory. Am I right? So it's not whether there is any suspicion depending on the history, depending on some clinical findings, but we routinely prescribe as a matter of protocol the TSH, at least we get it done, and if that is deranged, then we go for complete thyroid profile.
Correct. So that also we can do, but as per the
mostly we refer the patients to you. So we are
right,
important
right.
from that point of view.
Anesthesia won't give the clearance. Even if you agree कि चलो इसका नहीं करते हैं, still the anesthesia they will force you some. इसको करा के clearance लाना है. Because of the fact that hypothyroidism may lead to certain subtle complications, minor complications during surgery, which can be avoided if it is detected and if it is treated prior to an elective surgery.
Yeah, so my question is, sometimes when we have to operate an emergency, like patient semi-emergency, like an acute calculus cholecystitis or maybe an appendectomy, and the thyroid comes out to be, say, in the range of 20-25, in that case we do face problems with that. So what kind of risks?
That's exactly what I'm asking actually. Right. So I'm going in one sequence actually. So next
I'm
question.
sorry to breach that protocol. No, please continue.
No, it's fine, sir. It's
we are in a bit of that.
that makes the discussion lively. Yes, ma'am.
Like you said that routinely we need not do TSH for every patient, but are there any guidelines for the nature of the surgery or the duration of the surgery? Will that determine on in which patient we have to do the TSH preoperatively?
Madam, guidelines say that we did not routinely screen, but practically, as sir has said, we do it for all patients because it's an inexpensive, widely available test which can pick up a disease like thyroid dysfunction. So actually guidelines do not say that the nature of the surgery, the duration of the surgery, it doesn't have a role in determining whether TSH needs to be screened in a patient or no. Having said that, I would again like to say that if it's a non-cardiac surgery, say we are not planning for a PTCA or a coronary artery bypass surgery in a patient, then it is, in those cases, it is best to not treat a patient of hypothyroidism because it may precipitate angina and that may postpone the procedure which is required. So that is the only scenario where the type of surgery, whether it's a cardiac surgery or a non-cardiac surgery, can actually guide us whether we need to treat this patient or we do not need to treat this patient prior to the surgery. So if it's a cardiac surgery, then we may avoid, we have to avoid. So they say that because it may precipitate angina. But in other non-cardiac surgeries, there are no guidelines which would say that the nature of surgery, the duration of surgery.
In fact, in that context only, in fact, in cardiac surgery, if it's a mild to moderate hypothyroidism, you better proceed with the surgery and then replace later on, because otherwise the patient will land up in angina, and there are studies to that. And going to the next question to Dr. Arun, so what do you think the cause of raised TSH in this patient? Maybe briefly you can tell.
Yes, that is very important, because you mentioned the general consensus that if you have a documented normal TSH in last 3 to 6 months, you can directly proceed with the surgery without doing a test. But you have to talk to the patient, you have to go through the medical history. Maybe the patient has stopped taking medicines for last 2 months because the last test was normal. That is a common thing. I'm not talking about
non-compliance.
It is very common. Patient has stopped the medicine, and there could be other drug-to-drug interactions. I think a few points here mentioned. I think compliance, it could be a partial non-compliance, complete non-compliance, or the drug-to-drug interaction. So in this patient, she is being rightly treated with the calcium, vitamin D, but then the calcium, iron, PPIs, these are the common medications which have interference with the bioavailability. So I think compliance, and then not proper spacing between the calcium and thyroxine, that could be the other reason. At least minimum 4 hours is the advisable time gap between thyroxine and calcium and iron, and half an hour after taking thyroxine, no food or tea or coffee. So I think those are the obvious
I think the
reasons.
compliance and the history, little bit of history.
So consensus wise not required, but practically we get
practically it's important. Okay, so next question to Nilakshi, what could be the intra-op complication of hypothyroid patients, and to Dr. Arun, what could be the post-op complication of hypothyroid patients, in brief?
So since I said that since thyroid hormones, they have a role in almost all the systems, be it cardiac, be it respiratory, be it central nervous system or GI. So thyroid hormones may have a myriad of may lead to a myriad of dysfunction during the intraoperative and the postoperative period. However, the most important or the most relevant intraoperative complication is hypotension, because hypothyroidism can lead to a decrease in the systolic blood pressure, and systolic blood pressure is even lower than 70 has been recorded in certain patients. So that is one of the most relevant complications. Other is arrhythmias, that could range from STT abnormalities, from prolonged PR interval to sinus bradycardia, ventricular tachycardia in certain cases, but they occur with severe hypothyroidism or like moderately severe hypothyroidism.
Intra-op, it's mostly the cardiac problem that may happen, and post-op what can happen? And I think surgeons are more concerned about the post-op things, because the patient is out from OT.
I think
Directly on my head.
Directly under
Both
the
are
surgeon's
important.
care.
Right.
Earlier the anesthetist is there to look after.
Correct.
Yeah. So both are important for a successful surgery and right outcome. So intra-op, because it's a shorter duration, so cardiovascular become more prominent, and the same complications which can happen intra-op, there could be prolongation of same thing, or even post-op hypotension. But then post-op could be the manifestations of hypothyroidism or other systems, various systems. For the sake of simplicity, I can start from top, from the neurological. So delayed recovery or altered mental status, if it's moderate or severe hypothyroidism, then there could be delayed recovery from general anesthesia. These patients have increased sensitivity to opioids and anesthetic agents, and prolonged hypotension. I think paralytic ileus is the other concern. Many of these patients, if they have overt hypothyroidism, they also always have constipation, and even opioids are being commonly used in post-op situations for pain relief that can aggravate the situation, I think. And electrolyte abnormalities because of effect of hypothyroidism on water balance and effect on the kidneys. Hyponatremia needs to be looked closely if patient has severe or moderate hypothyroidism.
So, yeah.
Yes. What is the meaning of term myxedema coma?
Yeah, that's the next question I'll ask.
One thing, again, in a study which was done in hypothyroid patients, retrospectively, so it was seen that even in those who were moderately hypothyroid, even in them, it did not change the time of discharge, the duration of hospitalization. It did not increase the risk of post-operative infection. However, one important thing that was noticed was that patients with hypothyroidism, even if they have a post-operative infection, they may not have overt fever. So that is where we may actually miss post-operative infection because of this lack of febrile response in these individuals. So that
so
one
they may
thing.
not mount fever, paralytic ileus, and this thing delayed recovery and hyponatremia. I think those four are very important for surgeons when they are directly under their supervision.
And if I send such a patient for your opinion, what type of anesthesia would you recommend, regional or general anesthesia, seeing the risk of hypotension and all these things?
Yeah, so we are discussing a case of TKR. I think most of times it's not GA, the spinal.
It's
I think you are
yeah,
using
regional, most
for a moderate or severe hypothyroidism. So we call moderate or overt hypothyroidism when T4 is also lower than the normal limit. So we classify the severity of hypothyroidism conventionally as mild, overt, and severe. So mild is subclinical. You have normal T4 and TSH higher than normal. The next level is overt, when T4 has gone below the normal range, below the normal limit. And severe is when patients have overt symptoms of hypothyroidism, serious symptoms such as altered mental status, poor concentration, disorientation, and maybe heart failure, pericardial effusion, hypotension, bradycardia. Those are the overt and severe hypothyroidism. So for overt or severe hypothyroidism, unless until it's a life-saving surgery, I think GA must be avoided. But if surgery cannot be postponed, then you have to prepare a patient as a maybe potential case of myxedema. Sir was asking about myxedema coma. You treat him as a case of myxedema and take for the surgery. So myxedema is a combination of slow mentation with hypothermia. Those are the hallmark features, but then commonly associated findings would be hypotension, bradycardia, hyponatremia, and at times hypoglycemia as well.
Yes, thank you. So coming to the next most important question which surgeons are mostly concerned is, when should surgery be postponed in hypothyroidism, or when you cancel a patient due to hypothyroidism?
So mild and moderate hypothyroidism, as Dr. Arun has a while back elaborated, they can be given a green signal for surgery. So they need not, we need not postpone surgery for these patients. However, if a patient has been, once they are detected, they should be treated. Say they have been found today to have hypothyroidism, they should be treated, and the longer we treat, the better the outcomes actually. And when we treat a preoperative patient who has been diagnosed incidentally to have hypothyroidism, even if we treat them for a period of 7 days, that can normalize the effects of thyroid hormones on the cardiovascular, respiratory, GI, and the nervous system. So even 7 days is a good duration to offer for patients who are diagnosed preoperatively. The patients whom we have to refuse, so we have to know when to refuse.
Yeah.
So they say the best surgeons are the ones who know when not to intervene. So that is what we have been taught in medical science. So when not to intervene is when a patient has severe overt hypothyroidism, as in myxedemic coma, where the patient would be having symptoms of pericardial effusion, heart failure, he will be in altered sensorium. So those are not the candidates to operate upon. And having said that, one important thing is that surgery can actually be a precipitating factor for myxedemic coma in a patient who was not diagnosed preoperatively. So surgery, infection, these kind of stresses can lead to or precipitate myxedemic coma in a patient of hypothyroidism who was not on treatment. So we have to be cautious in such patients, and severe hypothyroidism is leading to myxedemic coma in a patient is an absolute no. In these patients, however, if they require elective surgery, then no, they should be postponed. But if it's an urgent or emergency surgery, then they have to be loaded guidelines say with IV levothyroxine, but since IV levothyroxine is not available in our country, so we cannot talk about that. What we can talk about is loading them with levothyroxine, that is T4 or T3. Ideally, T3 is the molecule that has its role, especially in this situation, myxedemic coma or severe overt hypothyroidism who needs urgent surgery, because T3 is the active form of thyroid hormone replacement. So they would lead to earlier normalization of the thyroid dysfunction in such a patient.
Yeah. So basically mild to moderate hypothyroidism, we can go ahead with the surgery. But for severe hypothyroidism, elective surgery is absolutely not indicated, and for emergency surgery, we have to load it and give an IV T4, T3. Unfortunately, it's not available, so we can load it with T4. So depending on the cardiac status again.
Sir, again, if it is a non-emergent surgery, like an elective or a semi-elective, once we have started treatment, for how long do we wait? And like as you said, 7 days is good enough. Should we repeat something after 7 days, because it will not probably change, the TSH is not going to change immediately. So should we, what should we monitor before we take up the patient?
TSH would take a minimum of 1 month actually, or 4 weeks, 3 to 6 weeks basically, to achieve that equilibrium. When we are giving TSH, it has to go to the pituitary, suppress the TSH. So that may not be an accurate reflection of whether there has been a correction of the hypothyroid state. But if the patient has had low free T4, and when we are replacing the patient, then normalization of the T4 in the normal range would also be it could be a factor which could favor a semi-urgent surgery. But if it's a completely elective surgery, then we would wait for a month maybe until the normalization of TSH has been recorded. And in such patients, the recommendations state that in these patients who require elective surgery and whom we are waiting for the TSH to normalize to do the surgery, we have to replace them in a full thyroxine dose, that is 1.6 microgram per kg body weight, unless the patient is a cardiac patient where we need to go with a slower or a slower up titration, that is go with a lower dose and gradually up titrate. But if it's a young individual who is less than 45 years, we can go with 1.6, and that is expected to lead to a normalization of TSH within a period of 4 weeks. So maybe that.
Yeah.
So
So
elective
Dr.
surgeries
Arpan
will
wants
be
to
up
ask.
to 4 weeks.
But if it's a semi-urgent, then we can repeat, say, the T3, T4 after a period of 7 days after full replacement dose, and then check if they have normalized.
Yeah, Dr.
I think loading T4 probably going off. It is more of a treatment for the patient, not for the patient, but for the doctors. I think it doesn't probably help change the outcome, because people with the myxedema coma, which is sort of very rare condition now, they probably don't die of myxedema, they die of parallel thing. In that point, I want to tell actually, because the surgeons are on the dais, that giving a hydrocortisone pre-operatively is very helpful, because some of these people are a little bit of a low cortisol can be there. That can be more of a problem rather than hypothyroid itself.
Absolutely, absolutely, and that's a very important point, sir.
Whenever we feel there's some problem, we give
That's a very important
the stress dose of
point which has
steroid.
been raised by Dr. Arpan. So once in patient,
It is taken as Ramban.
1 minute, you know, some GP told when that dexamethasone has come for the COVID. Anyway, we knew fewer dexamethasone to be given. Why you need study? This is exactly like that.
in fact, in severe hypothyroidism, the adrenal HP axis is at fault sometimes,
Yes.
and it is suboptimal. So we can replace, if you are suspecting myxedema coma, thyroxine and also hydrocortisone. So coming to the next important question, which is very pertinent to surgeons, is that on the day of surgery we keep the patient NBM, and post-operatively also in some surgeries which our esteemed sirs know, which surgeries you don't give for 3 to 4 days of anything by mouth. So what should be done in that case?
So actually, because thyroid hormones, they have a long half-life of 7 days. So even if we can skip the thyroid tablet on the day of surgery if it is mandated. We can skip the thyroid tablet for next 3 to 5 days if it is required or if it is mandated by the patient's condition. So there is no problem in skipping the tablets even post-operatively for up to 5 to 6 days. There is no problem in that.
We normally give on the day of surgery with a sip of water. Early morning we normally
Yeah, we
Yeah,
know.
even that is not also required, sir, because if the patient is euthyroid,
understand for 5
yeah,
to 7
yeah,
days is what a normal
yeah,
time.
yeah. So it may not be given if the
But what if
anesthetic.
patient needs to be kept prolonged
Yeah,
fasting?
that's
At
the
once,
question.
It is better to give on the day of surgery
If-
with a sip of water.
Yes, sir.
At
If
least
after-
we will have one more day.
Yeah, if after 5 days also the patient is not taking anything by mouth, then probably an IV thyroxine or maybe an intrarectal preparation should be done. So coming to the next thing, how do you prepare this case? Just in brief, what about this case? What you should have done? This is a patient who is stable, subclinical hypothyroidism, and free T4 is normal. So what you should do? TKR is planned.
So you can categorize her as suboptimally treated, or if she was newly diagnosed as subclinical hypothyroidism. And anyway, I think the surgery, though it is elective, but then spinal anesthesia and T4 is within the range, as Dr. Nilakshi already mentioned. For subclinical, you can always take the patient for surgery, but then treatment should also be not delayed. So if it was newly diagnosed, you need to initiate the treatment, but in this case, as we mentioned, there was poor compliance and then potential interaction between the medicines. So probably I'll not increase the dose, just continue the same doses, but just encourage the patient, motivate the patient to take it more regularly and increase the space between the time gap between the thyroxine and calcium, so that next time she has a normal TSH. Otherwise, making both interventions can make her thyrotoxic after 3 months.
And like we are surgeon friendly, so we would give clearance for this.
3 minutes, don't worry.
Okay.
I'm watching.
Right, sir. So I'll just.
And one more
Yeah,
thing,
yeah.
Sambit. In your case, in this case, the free T4 was normal in this
Yeah.
patient.
Free
So we
T4
can,
was
yes. So we can go ahead with the surgery without postponing on.
So in a
on the same.
corporate hospital, if you tell orthopedician you cancel the surgery and the patient
Next
is
time you're not
already
doing
admitted,
that,
I think you'll be thrown out.
So my question is, in case of normal T3 and T4, is there any absolute cutoff TSH value to which we should look at? Like I've been told that if the TSH is less than 10, probably you can take the patient, something
Even
like that.
guidelines recommend that.
This
Below
patient-
10, you can blindly go ahead with the case. But more than 10, again, you have to look into other things. Like, however, we should remember that the complications which are from mild or moderate hypothyroidism, they are very minor. So I think it has been overhyped a little. It's kind of a scare which is there. But these complications, the only one thing is that we have to be aware. So that is what makes it easier, I believe. So if you know that the preoperative TSH is 20, and even if you have to do a surgery, you still know what you have to look for. As we mentioned, what are the intraoperative, what are the post-operative complications of hypothyroidism. Once you are aware that this patient has a TSH of 20, you can still go ahead with the surgery, but keeping in mind that this patient may have these complications intraoperatively and these complications in the post-operative period.
So I think we had a discussion, but just wanted to summarize the whole thing. And while literature says there are many guidelines which has come from Mayo Clinic and other anesthesia associations. So what they have told is that they have divided hypothyroidism into 3 categories, but again I must tell that these are arbitrary. So that's mild, which is subclinical hypothyroidism, moderate, which is a overt hypothyroidism, that means TSH is high, free T4 is low, with or without symptoms, and severe is overt hypothyroidism with significant symptoms that includes altered sensorium, cardiac failure, pericardial effusion and myxedema coma. So these are the 3 categories of hypothyroidism. Perioperatively we can classify. And for subclinical hypothyroidism, I think for patients with subclinical hypothyroidism where TSH is high and free T4 is normal, we should not postpone surgery. For example, this patient, even for elective patients also, such patient can proceed with either urgent or elective surgery. So that's very clear for that. And this patient also we can take up for surgery. For moderate hypothyroidism where the TSH is high and the free T4 is low, plus or minus symptoms, which are the common garden variety of patients which come perioperatively. So patients with moderate hypothyroidism who require urgent surgery, it's reasonable not to postpone surgery with the knowledge that minor perioperative complications might develop, and we must know what are the complications that the patient might develop. Such patients should be treated with thyroid hormone as soon as the diagnosis is made, and we must give a full dose, what Nilakshi has told, it's about 1.6 microgram per kg per day. Older patient, we can start at a lower dose. When moderate hypothyroidism is discovered and the patient is being evaluated for elective surgery, I think it's better to postpone for some period of time, maybe for 7
Unless
days
it is
for-
an emergency.
Yeah, unless it's an emergency. Emergency, you can go ahead. For severe hypothyroidism, I think there lies the problem. And in patients with severe hypothyroidism, surgery should be delayed until hypothyroidism has been achieved. Otherwise, there would be various complications and the patient may be landed up in myxedema coma also. In emergency surgery is required, the severely hypothyroid patient should be treated as soon as the diagnosis is made. If emergency surgery must be performed in a patient with myxedema coma, treatment with both T3 and T4 rather than T4 alone is recommended. So that's a medical emergency and we must treat them like an emergency surgery.
Thank you.
So with that, I'll end.
Time
Thank
is
you for
over.
the patient.
Yeah.